Improving access to and use of quality maternity services to reduce maternal morbidity and mortality have been critical goals for the maternal health community throughout the Millennium Development Goal and Sustainable Development Goal eras. However, despite decades of effort, inequalities in access, use, and health outcomes remain persistent and profound. For instance, women from minoritized racial or ethnic groups, women of lower socioeconomic status, women from migrant or refugee backgrounds, women with disabilities, and people giving birth who don't identify as women may be more likely to experience intersectional discrimination on multiple fronts that results in poorer health outcomes and healthcare experiences. A more holistic approach to maternal health is urgently needed. Clinical care and healthcare experiences are profoundly shaped by intersectional gendered power relations, which are largely driving the inequities that we see in maternal health outcomes today. Intersectionality is an approach rooted in Black feminist theory and praxis and encourages exploration of how different types of power and privilege, and conversely oppression and exclusion, are interconnected and co-constitutive. Using an intersectional approach is powerful as it allows for explicit exploration of how gendered power relations interact with other sources of inequality to shape or impair agency, cultural expectations, and access to resources, support, and care during the perinatal period. Other deep-rooted sources of discrimination further intensified this gendered discrimination, including racism, casteism, ageism, ableism, and transphobia. There are many instances of racism deeply ingrained into health and social policies that govern maternal health today. It's important to note that this gendered racism has deep historical roots. Enslaved Black women were surgically experimented on without their consent or pain management by the father of modern gynecology, James Marion Sims, in the 1800s. In Australia, government policies forcibly removed Aboriginal and Torres Strait Islander babies and children from their families, placing them in non-Indigenous families. This led to intersectional experiences of compounding cycles of intergenerational trauma, including broken cultural, spiritual, and family ties, as well as distrust in the health system and inequitable health and well-being outcomes. Within maternal health, intersectionality analysis encourages consideration of women and birthing people as agents of the powers that govern their lives, rather than a sum of their social identities. Much has been accomplished by increasing access to and coverage of maternal health care services, with substantive reductions in maternal and newborn mortality. However, a substantial unfinished agenda remains to ensure that maternal well-being, rights, and justice for all can persist today.
Vulnerability as a concept in maternal health is centered around threats, barriers, and reparations, all in constant interactions with each other. During a woman's pregnancy journey, these vulnerability attributes can appear, disappear, change, or reinforce at any point through the continuum. For example, a teenager who enters her first pregnancy with iron deficiency is also likely to have other deficiencies like calcium, which predisposes her to preeclampsia. Now, if she does have access to good antenatal care, it is likely that she would have been commenced on calcium supplementation and aspirin, and also combined with regular blood pressure monitoring, her preeclampsia could either be prevented or identified early. But if she faces barriers to access respectful and effective care, her diagnosis is likely to be missed. When she finally reaches the hospital with severe preeclampsia, a cesarean section is often needed, with risk of postpartum hemorrhage worsened by her pre-existing anemia. Multiple opportunities will have been missed at various times of a pregnancy journey to help prevent this complication. We identified the key threats and barriers accounting for the disproportionately high maternal morbidity and mortality in low and middle income countries to be adolescent pregnancies, primary gravidity, first-time pregnancies, nutritional deficiencies, low education levels of the mother, and migrant and refugee status of the mother. Moreover, socio-cultural practices, norms that dictate women-specific practices pose threats and barriers to healthy pregnancies. Health emergencies resulting from conflicts, outbreaks like COVID-19, and the aftermath of climate events pose significant threats to maternal health services, particularly around the time of birth, when the risk of mortality and morbidity is the greatest for both the woman and her baby. We identified evidence for key reparative interventions to be iron and calcium supplementation, community-based educational interventions, financial incentive programs, and contraception promoting interventions. It is important that policymakers, healthcare professionals, and researchers use the vulnerability concept to improve pregnancy outcomes, using a preventative lens and a life course approach to rationalize increased resources for maternal health, identify vulnerability and customize care plans in maternity settings, and evaluate effective strategies to scale up the effective interventions, all done in partnership with women, their families, and communities.
We're all aware that the global health community has taken great strides and made significant progress in trying to address the key causes of maternal mortality. A lot of focus has been on early complications in pregnancy and childbirth, but there are huge numbers of long-term complications that arise during childbirth or emerge months or even years after childbirth that have been neglected. This translates into lack of visibility, financing, and lack of collective efforts in trying to address these conditions. Vesicovaginal fistula, which is also a long-term complication, is an exception because it has benefited from a dedicated stakeholder community, whereby we have a lot of advocacy as well as treatment guidelines. Within this series, we systematically search the global literature for epidemiological data on long-term complications that arise from labor and childbirth, as well as looking for high-quality guidelines on prevention, identification, and treatment. Our search showed that the most prevalent conditions are urinary incontinence, anal incontinence, dyspareunia, depression, anxiety. Others are secondary infertility, low back pain, as well as perineal pain. And high quality guidelines were actually available for some of these conditions, but they were developed and tailored for high income countries. We also documented the effective prevention of the long-term postpartum complications, which is actually through the provision of high quality evidence-based care during pregnancy, childbirth, as well as the postpartum period. We also identified research gaps, such as epidemiological research, research for intervention, as well as implementation science research. I would like to end with a call to action, emphasizing the importance of collective action, including all stakeholders, such as policymakers, healthcare providers, as well as the women themselves, and also the need for increased funding, as well as for conducting research to address the research gaps. Thank you very much.